I'd like to call up the panelists who are all listeners, they're all deep listeners. Professor Beyar, Professor Drazen, and Professor Horton to join on stage. And actually these questions were prepared not knowing exactly what the presentation by Jerry and Pamela would be, but they anticipated almost everything on these questions. They're there. I don't know if they can be put up so the audience can see them. We don't necessarily have to stick to them. Do you? Yes, I have them here. I don't see them on the screen. But they deal with, the first one deals with actually the question of uncertainty. A recent New England Journal paper by Simpkins and Schwartzman was on the topic of tolerating medical uncertainty, and my question to the panel on that was, to what extent should the health professional share his or her uncertainty with the patient? In other words, when can one be, and what times would it be more appropriate to convey a high level of certainty? And the panelists see the questions. I'll just summarize that they deal with how to deal with the questions that Pamela and Jerry talked about. When experts disagree, what does the family physician do? Sent their patient to 2 or 3 experts, and the patient comes back to the family physician, for example. Patients come in with internet data very, very frequently, often that the health professional has not had a chance to see. And what should the physician do when faced with new data that they haven't encountered, that the patient is bringing and they haven't had a chance to evaluate? There's a concept, and we've heard about it, evidence-based medicine. There's a sort of a new concept called medicine-based evidence, which relates to what we heard about, that is, patients putting their individual data for the public to see, sort of a democratization, but it doesn't always follow some of the statistical rigor that we might expect to draw conclusions, but may have a huge impact, and so forth. I also have 2 specific cases. One deals with a 52-year-old professor of physics diagnosed with triple-negative locally invasive breast cancer who got a standard oncology advice, but then went to Foundation Medicine and got a somatic genomic analysis, which took them to a whole different domain, which was not really recognized by the standard oncologist. What happens in that situation? And then another case was a 42-year-old litigation and personal injury attorney with 12 years of chronic headaches, but because of a family history of cancer, insisted on having an MRI, which wasn't necessarily medically what the physician thought was right after 12 years of chronic headaches with other possible likely diagnoses. To what extent does the patient's insistence and worry impact on medical decision making? So those are some of the questions. I would ask then the panelists to either address any of the points that Pamela and Jerry led us to think about, or use some of these questions as a springboard for addressing when experts disagree, the art of medical decision making. We'll start with Professor Beyar. Would you like to?
Well, I mean, obviously, I completely agree with the analysis that you presented, the beautiful logic and science behind it. And we see it on a daily basis. I mean, I'm a cardiologist, I'm an interventional cardiologist. Somebody needs a stent. I can have my opinion. I'm sure that if you will ask then the surgeon, they will come with a bypass surgery. It happens very often, and that's why the medical community is trying to force a heart team for any such decision that will involve cardiology and a cardiologist and a surgeon. But it doesn't happen to a large extent. It happens to some extent, as we all know, whether it's in the US or Europe or Israel. So this is one thing that shows that the mindset also depends on the profession. I mean, I'm sure that the surgeon will have a different mindset than an internist with respect to a disease that can be treated surgically or non-surgically. Same for oncology, same for different ways of treating patients. So it's there. The thing that we're missing, though, is applied data, and everybody interprets analyze data with the highest statistics to his own view, sometimes without really doing the fine statistics of adjusting the specific patient to the view of that individual. So there, I think that what we're missing is something that we discussed yesterday. A very, readily available system that will be able to take data from the current experience of a large center, or at least several centers if it can be combined, or maybe even the world, do a quick analysis and come to the right answer in real life scenario. This is your outcome and this is the number. There are few calculators here on the internet, but it's, refers to only very few established diagnoses that are wide in the population, but daily practice we have much more. So I think we still miss a very good data analysis tool on daily data set, data that are generated as a routine practice, and not necessarily the data that are of the randomized trial in a highly selective trial that does not necessarily reflect the individual patients that is there.
Professor Beyar, as an interventional cardiologist, as you started, if someone has a low prior probability of coronary disease but is very, very worried and comes to you after maybe a positive Bruce protocol, which may have not a very good predictive value because they have a low prior probability, but they're really worried. So it's like the MRI question. To what extent how far do we have to go in terms of an intervention to allay their anxiety, for example? This is the patient speaking and we're listening to them. Would you do a coronary angiogram?
I think the final decision is an interaction between your mindset and the patient mindset and the environment and that you are in. But you have to account for the patient mindset, and sometimes you have to decide even if the statistics are not for it, because you have to, as a physician, you have to see the entire picture, and it will never be in the big statistics. However we advance in our analysis and knowledge, there will still be gray areas that are left to the physician-patient interaction. That should be at the center of what we do.
Thank you. Did you want to comment? It looks like no, Richard?
Let me perhaps take a different tack. I can remember when I was a second-year medical student developing jaundice, and I went along to my general practitioner who knew I was a medical student, and his approach was to hand me a textbook of medicine across the desk and ask me to look up the differential diagnosis and work out what the hell I should do about it to help him make the right decision. So that was in 1982. By the time I qualified in 1986, in the days when we wore white coats around the wards, the book that every single young, newly qualified doctor had in their pocket was something called the Oxford Handbook of Clinical Medicine. This was our decision support tool. No iPhones, but this was the book that was perfect for the newly qualified doctor. Your bleep went, you were hundreds of yards away from casualty, patient had been admitted, shortness of breath, chest pain, and you had just enough time to read the one page that told you what you had to do for a patient who was admitted with shortness of breath and chest pain, the differential and all the rest of it. It was the perfect decision support tool. It even had a blank page on the right-hand side where you could scribble your own notes to remember. Now, fast forward 30 years or so, and I work at a medical journal, but it's part of a publisher. And the publisher sits on 25% of the world literature. And they have this idea that they can discover the Holy Grail, the perfect decision support tool. They own all of this information. And if only they could create the world's best search engine, the best algorithm, the best way to bring it all together into a product and deliver it to the doctor or the health professional at that point of care, then you've got that Holy Grail. And they've been struggling and trying and testing and failing for years. And will they get there? I don't think so. Not anytime soon, from what I see. So then try this other approach, alternative intelligence. I sit on a board of independent advisors for something called DeepMind, which is Google's alternative intelligence arm, so to speak. And this artificial intelligence arm, and what they're trying to do, they have a partnership with the Royal Free Hospital in London. And what they're doing is they get access to all the data for patients with renal failure, actually. And the goal is to take all of this information and to be able to predict when patients are tipping into, the patients who are stable are tipping into decompensated renal failure. And that way, you'll be able to predict when they're decompensating, save lives, and certainly save costs, which is a big issue in any health system today. Are they succeeding? Not yet, not yet. Now, if I compare my little Oxford Handbook of Clinical Medicine with our publisher's valiant attempts to create this holy grail, and Google's wonderfully inspirational efforts to use big data, I'm afraid at the moment I would stick with my little Oxford Handbook of Clinical Medicine. So although I'm a maximalist, and I'm a technologist, and what was the third one?
Believer.
I'm a believer. Oh boy, I'm a believer. But on this, I'm a skeptic.
Thank you, Richard.
You still didn't tell us. You still haven't told us whether you're going to send this lady to be cathed or not. That's the question. You can't get away without answering it.
I think one other aspect in terms of so-called artificial intelligence and so on, and I know some of the people have been working on the IBM Watson. So diagnosis, when you're going to tip into renal failure and so on. But then the other is treatment. So supposedly IBM Watson is going to give you, by this big data analysis, a set of milestones or landmarks, triggers when a certain cancer should be treated and how. And it turned out that Pam, as well as my nephew, who did a lot of artificial intelligence, made the point to me when I was thinking about this that the algorithm in IBM Watson depends on which doctor the IBM people were working with. So it turns out that they're working with a guy named Mark Chris, who's an oncologist at Sloan Kettering, who's a colleague of mine and a friend. But the way Mark Chris would treat lung cancer may not be the same way that Charlie Fuchs at the Dana-Farber treats lung cancer, or someone at MD Anderson, or someone in Rambam, or someone wherever. So the sort of hidden secret of artificial intelligence and big data is that it requires interpretation and application, and that those algorithms reflect the mindset of the physician who's working with the computer engineer.
Taking off from there, I wanted to ask Jeffrey to comment and also be more specific about a certain aspect related to what was said earlier. But since you just mentioned artificial intelligence, when Kasparov lost to Deep Blue, he wrote that his big fear was not that the computer beat him finally, but that people were starting to play chess like computers and not like people. That was his comment, that we were changing. And the question is that happening to us? And then more specifically we talked about the Oxford Handbook. I see what I encounter. I did a little on as attending physician on the excellent internal medicine department, and up to date, a nephrologist, Bert Rose, who we both know because he was both at the Beth Israel and the Brigham, and it went from nephrology to become almost the equivalent, right? Because it's on your iPhone. So, Jeffrey, I wonder if you could comment on the handbook, up to date, and anything else you want that relates to this decision making.
So the handbook, we had the Washington Manual, yes. Other side of the pond, same approach, was mostly diagnostic. What are the 6 causes of shortness of breath? Right, pneumonia, pulmonary edema, pulmonary embolus, pneumothorax, asthma, and airway obstruction. Right? And how do you differentiate them? And once you've differentiated them, what do you do? It's very black and white. Those are sort of acute care situations. less room for thinking about it, because those are usually short term. You have to solve a problem that's arisen. As you get into things that are less time critical, and you can think about them more, you really get into this dichotomy that I think Pam and Jerry brought out. There's some things that you'd be a fool not to do. Somebody clearly has a bacterial pneumonia. You've got a pretty good idea of the cause. You'd put them on some antibiotic, and then you can have an argument with 6 different people about what it ought to be. Most of the time, you're going to get close enough to make a medical difference. Then there's the other thing where exactly what you do isn't quite clear. And that's, you gave your thyroid nodule story. That woman, having gone through 3 biopsies, I would have the thing out by then. And that's because you never believe a benign diagnosis from an aspiration, especially an inadequate aspiration. Unless she came to you and had a fear of surgery and was trying to avoid it and was looking looking for you for reinforcement that she wasn't crazy for doing that. And so then you have to play the scenario out. Okay, what happens in 5 years' time if it turns out that you were both wrong, that it was a malignancy, and that her life was now in danger when before it wasn't, versus the short-term risk of having hoarseness or difficulty swallowing after this thyroid surgery. And help her work through this. I think that for the person that demands the testing, the coronary angiogram, she's had this Bruce protocol, she didn't develop chest pain, and the likelihood is pretty low, and you can start telling her about the terrible things that have happened to people that have been cathed. They've normal coronary angiogram, but then they lost the leg or an arm because of a huge blood clot. And that, so that is, you pointed out, you can never guarantee an outcome in this game. And I think that we have to, and I came into medicine from engineering, where, and I think Jerry in one of his pieces that he wrote for us talked about the Toyota manufacturing approach, where you could do everything exactly right. And he said the problem is that as doctors, we're all dealing with used cars, and you're coming in with broken pieces. We can't define the input. And so that is our interface between science and art. And I don't see it ever going away. I think that all these decision support tools, I don't know about you guys, but when I practice medicine and the little thing pops up. Do you all remember the Microsoft paperclip for Microsoft Word? It would sort of pop up and give you hints about how to use Word, and you try to get rid of that thing, because it was bothering you, because you couldn't. When you're busy seeing patients, the last thing you want to do is to have some voice in the background. Now, when you're seeking information, that's different, but to have something sort of creep in, you don't want it. You know what you're doing, and you're trying to get through it. So we're living at this interface. We're trying to do the best we can. We need to understand the patient and what he or she wants and helping solve their problem. And I think that when we go to see a doctor, we don't want to be treated like a number. We want the person on the other side to understand us. And I think that that's always been the problem. You have all these people who've been successful in industry, they're going to tackle medicine. You mentioned take GE has tried to do healthcare, and Google's tried to do health, and it's very hard to do, and it's because every one of us is different. And understanding that difference is what makes a good physician a great physician.
I know you want to comment, and also I heard last year we had some speakers who said this is all fine, but there aren't enough health professionals in the world to access all the people in need, and therefore electronic systems, decision support systems, or direct information to patients just expands the reach of medicine at a price, admittedly at the price of the being able to capture the patient mindset. So I don't know, you were going to comment on something else, but I think there is an issue of not enough health professionals and using electronics to extend even at some price of loss of the interface.
So I actually wanted to come back to your comment about chess and playing chess like a computer versus playing chess like a human being. And one of the things that we found was how important language can be. So, for example, when you're trying to do a differential diagnosis and somebody comes in and says, oh, I have a weird feeling in my chest. Now, is that chest pain? Can you enter that as chest pain? Or is that something else? So there's a little vignette that Jerry and I wrote up about a patient, an older man who had had coronary artery bypass graft surgery. And after he had the surgery, he was much more active. He was able to walk and play golf, which he hadn't been able to do before. And he came in to see his doctor, and he said, you know, I'm having problems with my stamina. So he had a big cardiac workup first. Everything was okay. Then he had a big pulmonary workup. Everything was okay. And then somebody started doing lots of tests, and they found that they decided to check his testosterone. He was in his late 80s. So his testosterone was 1 point below the normal range. Very minimally decreased, in fact, very good for somebody in their late 80s. But he was sent to an endocrinologist. And so he said his story about the golf course. And so he said, well, why don't you tell me a little more about what you mean by you losing your stamina? And he said, well, I get off the cart and I start walking and then I lose my stamina right here. And so what he was talking about was what we might call, in medical terms, intermittent claudication, where he had a block in the arteries in his leg. And that's what he meant by stamina. So sometimes you can be so misled when you follow sort of what might be a computer-directed way of thinking. Chest pain, here's your 6 causes, go this way, without really thinking in a deep way about how the patient is communicating in language.
Great. Thank you. I'd like to be able to open it up to the audience for about 5 or 8 minutes before moving on, unless there's one of the panelists is absolutely feels that they must say something. Okay, so I don't know if there are some comments or questions. It could be about this panel or maybe even the morning session from anyone.
Is it over there?
I can't, the lights are shining on me, so I can't really see. Right, okay, Professor Javid. Chief of Radiology here at Rambam.
Thank you for this exceptional discussion, but I would like to suggest to you, thank you, I would like to suggest to you that I perceive a failure in education that may be pertinent to your discussion, and specifically I'm referring to a lack of uniformity and lack of standardization for quality of evidence in studies. And if we were able to achieve some consistency about what represents good quality evidence in randomized controlled trials, we would go a long way to having the evidence be sacrosanct, which it is not, and have the interpretations of that evidence be far more harmonized than they are now. An example of that would be the Canadian breast cancer screening study. You may be familiar with the havoc that raised with regard to breast cancer screening, and that study, by all measures, in my opinion, is completely flawed.
Who would like to address that,
I'm happy to answer that. The problem that I see it, as I see it, and I think many people in the evidence-based business see it, is that no one has ever designed a good controlled trial. And that's because we're dealing with people. You have to come up with inclusion and exclusion criteria that right away limit your population, and there's always somebody who others feel should have been included and didn't, weren't included, or should have been excluded and weren't, what you're choosing for your outcomes, so that all this that we do, the best evidence we have is mostly guidance. See, there's some things where we have a really powerful intervention that give us an answer. If you've got hepatitis C, Now, you want to be on one of these new drugs, 99% cure rate in 12 weeks. And that's pretty clear. But those are rare events. Most of the time, we're looking for the difference between pretty good and not so good. And there's a big gray zone. And we can't get away with it. This is life. We don't have perfect interventions. So some of you who are wanting to think about doing research, we're probably better off going back to the lab to try to get a better idea of new ways to cure things. But we have to live with what we have, and it's not the trials that are at fault. It's our interventions, our ability to define and diagnose disease, and our ability to follow it up. And the interventions just show how powerless we are to really make a difference in many cases.
Yes, Professor. Oh, yes.
Just to quickly add to that, I think there's all. I love the phrase mindset, but there's another word that certainly impinges on the way trial evidence is interpreted, and that's ideology. So if I think about screening mammography, one particular person who's admirable in many ways, Peter Goethe, is linked to the Cochrane Collaboration Unit in Copenhagen, and he made it his life's mission in a series of publications to destroy any evidence that was supportive of screening mammography by picking apart the trials and doing exactly what Jeff has pointed out. You can destroy any trial if you interrogate it strongly enough. Because it was under the logo of the Cochrane collaboration, he was phenomenally effective. Now, it is true then that you're also dealing with, I've forgotten the name of the guy in America, but he's a exactly, that's right, who's rabidly the opposite way. Now, are these mindsets or are they ideologies? I mean, I think that we have to be sometimes a little critical about the fact they're not only mindsets, there are interests at play here, and those interests can be very damaging. Just very quickly, one other example, you mentioned statins. I'm not going to mention the journal, but there is a journal that under the rubric of campaigning against overtreatment, because it's got itself into a mindset that we're all overtreating patients, when it jumps on any evidence that it possibly can to then say, here's another example, proof positive. And so the ideology comes before the evidence, and the evidence is used to support the ideology. And I worry about that very much, because then I think you're getting into almost quasi-political battles and not looking at the science at all.
Ideology or agenda, let's say. Anyone want to comment on that? Okay, I think there is an agenda. Oh, let's see. Yeah.
Question over there.
Yes,
Yep.
Richard Lipchinsky.
You talked about the chess model versus human model. In the last 10 years or so, we've been going much more towards checklists and guidelines and timeouts. And my experience has been that people stop thinking when they have a checklist and they have a timeout. And how do we, in the week before the Joint Commission, how do we balance getting people to continue to think outside the box when they're constantly forced into a box?
I think even though there actually have been trials on checklists and so on, and some of them are positive and some of them are negative. The Canadian one was negative, one through the University of Michigan was supposedly positive. I think it depends on the indication. So when you have a discrete procedure, like catheter insertion, which was the paradigm of the checklist from Peter Provost at Hopkins and then Atul Gawande expanded it and so on, that you go through a very discrete set of steps, and it is apparently successful, because if you look at the catheter infection rates at our hospital and other hospitals, they've dramatically come down. The problem with checklists when people come into a primary care doctor or an internist is precisely what you say, that they completely constrain the thinking, but they fit into this model of quick diagnosis, very short time for appointments, here's your prescription, and out you go. And that is not successful, I think, in a lot of ways. There is another problem. There are these metrics that the government has imposed for Medicare, and the insurers have come in, and they have almost completely failed based on certain checklist kind of approaches. For example, you must give antibiotics within 30 minutes of hip surgery. So the entire surgical team is completely looking at their watch, trying to make sure that they're within the 30-minute time period, otherwise they get punished financially and get a demerit, a bad score on their quality. They're not looking at the patient and the outcome of hip surgery looked at for a checklist with that metric versus just the surgeon doing what he or she usually does. The non-checklist has a much better outcome in terms of integrity of the hip and so on. There was the disaster with community-acquired pneumonia, that you had to give antibiotics within 4 hours. That means everyone with a chest x-ray that showed haziness got antibiotics. Well, a lot of people had congestive heart failure. And then they developed Clostridium difficile colitis from the antibiotics. So the sort of top-down standardization can backfire and has backfired in a number of places.
Okay, I'd like to, I think it was, a very thought-provoking panel. I think in terms of agenda and ideology, the one that maybe we'll all agree on is humility. I think we all learn that we have to be humble and listen. And I think among all the different thoughts, that's something that I've taken away from the panel. And I'd like to move on to the final session. I want to thank the panelists very, very much.